Okay, we're getting into our abdominal assessment. This is chapter 22 of your big textbook. Kind of our normal outline here, go over the structure and function, get into our subjective data and how we take our health history, and then we're going to, from there, go into our objective data and gathering our assessment data through our physical exam, and then discuss some abnormal findings. So structure and function, the way I like to think of the abdomen is, and terms you want to be familiar with, are 4 quadrants. In a few slides I'll show you a picture of it, but there's a lot of things going on in the abdomen. So this is I would say, the most common complaint in the emergency department where I work is abdominal pain. There's so many things in there, there's so many things that could go wrong. There's a lot of different layers of tissue that can be inflamed and cause pain and not be anything serious. And that actually bothers patients even more if they come in to the emergency room, they have abdominal pain, and we rule out everything that's an emergency, but they still have abdominal pain. So something to think about there. These are all the things in our abdominal cavity. There's the liver, the gallbladder, the stomach, the spleen, your aorta, pancreas, kidneys. And like I said, there's 4 quadrants. We're going to go through each quadrant. And what I would encourage you to do, and how I feel like I learned the abdominal assessment the best, is I drew a big diagram. And as I'm looking at my patient, and made it into 4 quadrants. And I listed all the organs in each quadrant and what could go wrong with each of them. So I'm going to skip ahead and show you what I mean about the, like right here, see on the left. So if you're looking at the patient, this is their right upper quadrant, this is their left upper quadrant, left lower quadrant, and right lower quadrant. So this is when you're referring to pain for patients. Sometimes people say they have epigastric pain, which just means this area that's usually our esophagus or our stomach causing the pain, or it can be the heart. Umbilical is the region surrounding the umbilicus or the belly button. Then this is most commonly called suprapubic. I don't think I've ever heard anybody call it hypogastric. Okay, let's go back. So if you want, what I would do when you're studying or when you are going through the lecture, make that diagram and start to fill it out. Now, of course, it's not for everyone. I'm a visual learner, so that's how I like to learn. But your right upper quadrant has your liver, your gallbladder, duodenum, the head of your pancreas, your right kidney, which is anatomically posterior or in the back, and your adrenal gland, part of your colon, part of your ascending and transverse colon. You do need to know where all of these organs, where they are and which quadrant. You need to know them for this course, probably for your next exam. You also need to know them because these are really important organs that can cause your patient's problems. So regardless of where you work or what you do, everything involved in the abdominal cavity is important to know. So left upper quadrant, we've got our stomach, our spleen, the left lobe of the liver, the biggest part of the pancreas, the body, left kidney and the left adrenal gland, splenic flexure of the colon, and part of your transverse and descending colon. And I think it's a little bit easier to go through these with a picture, but we'll go through them and then go through the picture as well. Okay, so now we're into the lower quadrant. So when we get lower, most people know where their appendix is, that right lower quadrant, mostly because if anybody has had abdominal pain and it's in that region, everyone is concerned they have appendicitis. So your appendix, your right ovary and tube, if you have an ovary, your right ureter, and the spermatic cord on the right. And in the left lower quadrant, you have your descending colon, sigmoid colon, left ovary, left ureter, and left spermatic cord. Now right in the middle, and we talked about this in the cardiovascular lecture a little bit, but the aorta goes right down the center of our abdomen. So a patient could be complaining of abdominal pain that radiates into their back, and they could actually be having a ruptured or bleeding or something going on with their aorta. Uterus, not really easy to palpate a uterus centrally unless it's enlarged, usually due to a fetus being inside. Same thing with the bladder. For the most part, your bladder is going to be lower in that suprapubic area, but if you had a very distended bladder, you would be able to palpate it, or it would probably be very uncomfortable for the patient as well. So, okay, so here's a good visual. So the left, this is just showing you where all the muscles are. You can see that inguinal ligament, which you'll learn about in the PowerPoints for GU. This is inguinal hernias come down through this little hole here and here. And then I really like this picture on the right. The liver, you can see how big the liver is. And you could see how anatomically, if your patient had a rib fracture here, how it could be concerning for the liver if it got cut by the broken rib. So the liver is a very, drawing a blank here, it's very vascular, there we go. So if the liver gets cut, it can bleed quite a bit. So especially for trauma patients where I work with rib fractures, we really worry about bleeding from the liver. You can see the gallbladder right underneath the liver here, this little thing here. And everything's really layered up in there, so you can see how inflammation in one organ could really affect the others. Your spleen is up here, stomach right there. You can't really see the pancreas from the front. Ascending colon. This is the appendix, this little tiny useless piece of tissue here. Bladder's hiding down here. This is the sigmoid colon. Here's your small intestine, descending colon here. You can see how it all relates to the belly button or umbilical cord. Another good picture here, if you see, so here's our sternum, and this is our xiphoid process. So if any of you have taken BLS or have taken a CPR class, which you will eventually do, you can see how if you did CPR too low, you'd be poking this pointy, sharp bone right into the patient's liver. So that's why it's important to keep our CPR right up here. Okay, so we've taken out that outer layer of organs so you can see the ones on the inside. So this is the pancreas here. Here's the body of the pancreas in that left upper quadrant. And our kidneys are here. Important with the kidneys, because I think a lot of people think their kidneys are in a different spot, but they are actually a little higher and more posterior than a lot of people think. So there's a lot of stuff going on right here. So if your patient has mid-abdominal pain or mid-back pain, it can be really hard to figure out what's going on. Here's your inferior vena cava, your aorta, left ureter. So your patient has kidney stones. Their pain is going to be right back here. Any sort of kidney infection, they're going to have pain. I guess we'll look over here. It's a little bit better. Posteriorly, here's the 12th rib. So if you can find their 12th rib, go right underneath it. That's where the kidney is. And we'll talk about some assessment techniques further down, but remember where this is located and how we're going to assess the kidneys. So you can see here, if you've ever had a kidney stone or known somebody with a kidney stone, the left ureter and the right ureter, they are, they're really tiny, and if they have a kidney stone and it gets stuck in here, that's what causes that big pain that they have, or they get really uncomfortable. If you've never had a friend or know anybody with a kidney stone or have experience with that, it is the most relatable pain to labor that I've ever seen, and I have had women who've had kidney stones actually say that their kidney stone hurt worse than their pregnancy. Now, I don't know if that's just because in the moment they're experiencing the kidney stone more at the moment, and at least with pregnancy and labor, you get a baby at the end. But you can see the ovaries here, And here's the uterus in relation to the bladder. This is our pubic symphysis. Okay. Again, this is how you're going to break up your quadrants. A lot of times in nursing, like when I'm describing my abdominal assessment, you want to describe where their pain is. You can't really say the patient has a pain in their appendix. You would say this patient has right lower quadrant pain for 2 days with nausea, vomiting, things like that. That's how you're going to describe those assessments. Okay, we're going to get into our subjective data. So we're going to do our health history here. So things that we want to ask the patient is having an abdominal complaint or getting to their abdominal assessment is, how has their appetite been? So, some people, they just always don't eat a lot. There are people who don't eat, and if that's normal for them, then that's fine. But if they're normally a healthy eater and their appetite has decreased, we want to know details about that. When did it start? Is it affecting, are they having weight gain or weight loss? Are they eating too much? This is, we want to really dig into that if they're having any sort of changes in their appetite. Dysphagia is difficulty swallowing. This is important for patients, especially who have had a stroke or elderly patients, because we really want to know if they can swallow their food appropriately, because if they can't, they could choke on it. It could get into their lungs and cause an aspiration pneumonia. Anytime a patient has a stroke, we automatically have to do a swallow screen on them because we need to assess if they can swallow, so to prevent that aspiration pneumonia. It's really important. Food intolerance, this is, I'm sure at least one, if not half of you have some sort of food intolerance. So, that's lactose intolerant, that's a gluten allergy, that's, any sort of, if they eat a certain thing and it causes any sort of disruption in their body, that's what we're talking about with a food intolerance. Abdominal pain, we want to get into our PQRST mnemonic, really dig deep in here. The abdominal assessment, I think, is one of the most important. Subjective data is super important in an abdominal assessment because a lot of the pain that comes with abdominal assessments or with abdominal pain comes from, different organs that have pretty informative pain, I guess. So if, for example, the appendix is in the right lower quadrant, usually these patients have pain in the right lower quadrant or around their umbilicus. So, and usually it's only been going on for a few days. It's pretty constant. It doesn't really come and go. And I'll teach you an assessment technique a little bit further down called rebound tenderness. And these patients are pretty classic. Not always, but really important to get the history around the abdominal pain. When did it start? What makes it better or worse? Same thing with a gallbladder. Usually if a patient's gallbladder is acting up, their pain is going to get worse after they eat, especially if they eat something really fatty or high in fat or not very healthy. So really diving into that abdominal pain. Have they had any nausea, vomiting? If your patient has diffuse abdominal pain with nausea and maybe vomited once, that's different than a patient with abdominal pain, nausea, and has vomited 20 times, right? Because then we're worried that they had some sort of, they could be dehydrated, they probably need fluids. It's just a different assessment. When they're vomiting, we want to ask them what they're vomiting. What does it look like? Is there blood in it? A lot of times, especially if someone has, for example, food poisoning, or some, if they have norovirus, which is this terrible, terrible nausea, vomiting, diarrhea illness, they will vomit so much that it'll upset their esophagus and they'll get little specks of blood. And that causes patients to freak out, rightfully so. Usually it's totally fine. So unless they're actually vomiting up quite a bit of blood, then we're not too worried about it with the little specks. Bowel habits, really important in the abdominal assessment. So what is their bowel habit normally like? Has it changed? Are they constipated? Are they having diarrhea? Important to know especially if you're looking for something like a bowel obstruction. You don't want to skip over that, especially in our elderly population. Abdominal history. So, do they have all their abdominal organs? Do they have a history of having the same pain before? Your patient could very easily know, oh yeah, I have a problem with my gallbladder. This pain feels like my gallbladder pain. I think it's time for me to get it taken out, that kind of stuff. So abdominal history is always really important. And do any of the medications they take affect their bowels? Patients with on blood thinners, we really want to assess them for any blood in their stool. When we're asking about their bowel habits, we do want to ask if they notice any blood in their stool. And it's a good time to educate patients, especially if they're on blood thinners or have any constipation history, to make sure they look at their bowel movements when they have them. Blood in stool can be fine, or it can be very scary. So a dark red, like maroon type color of stool usually has this very awful smell, is usually indicative of a gastrointestinal bleed. So somewhere in that patient's GI tract, they had an ulcer or for some sort of reason, maybe the blood thinner popped a blood vessel and they're bleeding internally. It's getting digested and then it is coming out. It's very, very terrible smelling. You will never forget it after you smell it one time. So that's why it's important to ask them about the blood or the color of their stool, especially if they're on blood thinners, especially if they have a history of any sort of gastrointestinal bleeding in the past. Other medications can cause constipation, like all narcotics cause constipation. Different medications can affect bowel habits. And then you want to do your nutritional assessment. So, a lot of times we'll see little old ladies or men who just, their taste buds kind of go to the wayside as they get older. They just don't want to eat very much. And so these are people you might need to start giving some sort of nutritional shake to, or get some way for them to get their nutrients in if they're not eating appropriately. Oh, I saw this the other day and had to post it on here because I was about to do my GI assessment, and that is the most accurate depiction of a GI bleed. And when you smell it for the first time, like I feel like I can smell it from across the ER. Like I know if there's a patient with a GI bleed in our department. It's very upsetting. Okay, objective data. So now we're going to do our assessment. So the abdominal assessment can be so very, very in-depth. I am going to teach you the basics. If you want to become a nurse practitioner or a PA or a provider and go more into depth, and actually the book does a really good job. If you're just curious about how to do a very detailed, in-depth physical exam on the abdomen, you're more than welcome to. But it's very, the structures in the abdomen can be very hard to palpate, especially with our population of patients who are getting a little bit larger, and America has a pretty big problem with obesity. Unless you're a skilled clinician doing these assessments multiple times a day, it's really hard to do really in-depth assessments on the abdomen. So I'm going to go over what I feel like is the important part of an assessment and a basic abdominal assessment. I do these all the time, and I still don't do a lot of these detailed. I'm not feeling for the spleen and the kidney and the liver every time I do an abdominal assessment because, well, I'd just be behind all the time because these are very detailed assessments. But if you're a provider in an office, sure. Okay, so preparation. We want to have the patient's abdominal assessment is really good for. It's really important to have a comfortable patient in. So I always get my patients warm blankets. You want to make sure they are relaxed. If your patient has abdominal pain, you pretty much always want to obtain a urine sample. So my kind of practice is I bring them back to the room, I show them where their room is, and then I give them a urine cup and I instruct them on how to do a clean catch urine specimen. And then I'm having them empty their bladder at the same time as I'm getting that urine sample, and then they come back to their room, and then they get changed into a gown, bring them some warm blankets. They should be relaxed. Pillow, You want to have a pillow so they're not cranking their neck back. Warm up your stethoscope because that'll make them tense up, and that can affect your abdominal assessment. You always want to palpate the painful areas last, and with a lot of caution, because the doctor's going to come in and do a very detailed painful assessment as well. So, think about how you can make it the most comfortable for your patient. This preparation for these patients is super important. So I really want to make sure that you understand and know why you're doing all these things, and that it's you do need to know all of these measures to help with abdominal wall relaxation. You're going to get your stethoscope, and alcohol swab to clean your stethoscope. Okay, we're always going to inspect first. So you're looking at the patient, you're looking at their abdomen, you're providing them as much privacy as you can. You're looking for the patient's demeanor. So the patient in a lot of abdominal pain will look very uncomfortable, and it'll be very difficult to assess their abdomen. So, they might be balled up, holding their stomach, vomiting. These are things that you are observing to help you with your assessment. And then we're going to listen. So it's important to listen second. You look first. We always look first, and then we listen. When we're listening, because you don't want to push around on someone's stomach before you listen to what's going on in the stomach. So if you push around on the stomach, there's going to be some gurgling when you go to listen. So you always want to listen next. Percussion. Again, this is very old school. Of all of the percussion techniques of providers and examiners, percussing the abdomen is one that I do see providers every now and then still do, because it basically tells you, is there air in there? Is there something hard, or is there fluid? So, again, the book does a really good job of, if you wanted to get into the weeds with that, but I'm not going to cover it for this lecture. Light and deep palpation, all 4 quadrants. Again, I'm not going to have you palpate the liver or the spleen. I always do light palpation. The last thing I need to be doing is pushing around on my patient's belly who's coming in for abdominal pain. I'm just going to make them more uncomfortable. So I will do light palpation to make sure I don't feel any large hard mass or any pulsations, but I'm very careful. Patient comfort is also very important. Okay, let's see here. So we're getting into the details of all these. So we're inspecting the abdomen. These are words you could describe. If you look at the diagram on the bottom right, flat, scaphoid, rounded, protuberant, you can kind of see the difference in what those would describe. You're looking for symmetry, so is one side bigger than the other? Looking at their belly button, do they have a hernia that's bulging out in the middle of their belly button? You're looking for scars, because if a patient has a scar on their abdomen, they probably have an abdominal history, so you want to ask them about that at this point. Striae. Striae is a big, fancy, I guess it's not big, it's short, but short word for a white or red linear kind of jagged, I guess they call it, I don't know if you call it a lesion, but these are stretch marks. Striae is just a stretch mark. So you can see on the patient above, they're measuring the stretch mark. They're usually greater than 4 centimeters. You're looking for any pulsations or any movement. Movement, you're not going to see movement a ton. You might be able to see a patient's, if they're pregnant, you might be able to see the baby moving around. Hair distribution, for that, they're just getting to the point of patients with some hormonal abnormalities can have some weird hair distribution. All right, so how do we describe bowel sounds? We're going to use a diaphragm or a stethoscope. They are going to be normal, hyperactive, or hypoactive. I was trying to make up a word that didn't exist there. Borborygmi, another fancy word, that is what we call when our stomach is growling or making those gurgling noises. Absent bowel sounds is, you can't technically document absent bowel sounds unless you listen to bowel sounds for greater than 5 minutes. So that's a very long time to listen to bowel sounds. Post-surgery, when they're worried about the bowels not working, what's more important is the patient passing gas and having a bowel movement, but they might be absent after surgery because, they shut everything down, but you do have to listen for 5 minutes to be able to say that. I'm not going to go through the vascular sounds, but just know that in 5 to 20% of patients, you could technically hear a bruit in one of these arteries. Again, percussion, tympany, usually most commonly what you're going to hear in the abdomen is just from the air in the abdomen. I'm not going to teach you the liver. I do want to go over the costovertebral angle tenderness, though. This is something that I will do if I'm worried about the patient having either a kidney infection, which we call pyelonephritis, or a kidney stone. So for these patients, and if you need a visual for this, these patients, you put your hand flat on their back below that 12th rib, and then you use your other hand to make a little fist, and with the pinky side, you're just going to lightly tap, like tap, 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 tap. And the patients with kidney infection or anything going on in their kidney where it's inflamed, this would be severely painful for them. So just do it once or twice, and if it's painful for them, you'd want to move on, check the other side, and then you document positive CVA tenderness or no CVA tenderness. So that one is important. We do that a lot, checking our kidneys. What else about this? Did want to mention peristalsis. I don't think we've gotten to that yet, but that's just the muscle contractions in our stomach that kind of help things move along. So that's what we're hearing is the movement of the abdomen. We're gonna go through NG tubes in lab. An NG tube is a nasogastric tube. So I want to talk a little bit about the assessment of that here as well. So if your patient is, had a bowel surgery because they had a bowel obstruction and they had to get an NG tube, we'll go over this more in lab, but when you initially put in a nasogastric tube, the best practice for how to assess if your NG tube is in the correct place is to get a chest x-ray and confirm visual placement with the physician. So that is 100% best practice. If you work in a place that has a chest x-ray, you should always get one for patients when you put in an NG tube. The reason for this is an NG tube with enough force, or if it's a weighted NG tube, can, instead of following the path down to your stomach, it can follow the path into your brain. So that actually happened at a local hospital a couple years ago, and they had to completely change their policy. They panicked and they stopped allowing nurses to do NG tubes at all. It was a weighted NG tube. It's very, very rare that this happens, but if they would have gotten a chest x-ray, that would have been avoided. So it's best practice to get a chest x-ray to confirm your placement for an NG tube here. Now, if you work in a nursing home and your patient has an NG tube, or you're just doing your assessment, so the NG tube has been in and now you're following up with your assessment after they came back for surgery, or maybe they went and had a procedure and you just want to check placement because you're not sure, you think maybe the tube moved a little bit, you could take a syringe and aspirate some of the stomach products out of the NG tube and then use a pH strip and test the pH. It should be less than 5.5. And that's the same if you work in a place that doesn't have capabilities to get a chest x-ray, is you can aspirate the pH of the material, and as long as it's less than 5.5, you should be, that tells you that the pH of the stomach aspirate is in the stomach and where it should be. So that's really important to know. That's kind of one of my soapboxes. I really don't ever want any of you to put a NG tube in the wrong spot and then hook it up to suction or put any medications down it and have it be in the brain, right, or in the lungs. So, carrying on. This will make more sense once we go through it in lab too, if that sounds like a lot. Okay, palpating the abdomen. Again, you want to do all those relaxation methods. You always want to do your light palpation first. Again, it's not common for me in my practice to do deep palpation. Bimanual is just when you're using both your hands. This is yeah, I'm not going to go over most of this stuff. So yeah, you could assess the spleen, you could feel for the liver, you could feel for the aorta. I will sometimes put my hand just lightly on the belly to see if I can feel the aorta pulsation, but it's not very common. Rebound tenderness. This is an important technique that I do on all of my abdominal assessment patients. When you do rebound tenderness, you're assessing for peritoneal inflammation. So any inflammation in that stomach, any of those walls. So patients with appendicitis often have rebound tenderness. So what you're going to do is push down slowly and gently, but with enough pressure to, get a little bit of depth in the abdominal wall. You're going to push down slowly, and then you're going to release quickly. And patients with any sort of inflammation in their belly, when you release, the pain is going to get significantly worse. Obviously, you don't want to do this more than once if it's positive, right? But that's how, if my patient has right lower quadrant pain and I push down over where the appendix is and let go, and the pain gets worse, that patient's getting a CAT scan and they're concerned for appendicitis. Inspiratory rest, this is a Murphy sign. Basically, you would push where the gallbladder is just lightly, and then you'd have the patient take a deep breath. And usually this would be very painful if they do it. So all of these procedures, you can maybe see why I don't do them that often, but they're painful, right? So iliopsoas and obturator tests are two other tests that test for peritoneal inflammation that I don't see commonly done any longer. Here's another. So this is the diagram telling you like what all the things you should be able to palpate. Very, very difficult again to palpate these structures if you are not a very advanced clinician. I like this diagram because it can really help you assess when your different organs are acting up, where you're going to feel the pain. So I would be familiar with this. This is a good tool to have in your toolbox for just anytime you're assessing your patients. Okay, so here's just different types of abdominal distension. Obesity is pretty straightforward. Pregnancy, constipation. Patients who have distension due to constipation, these patients are severely constipated and very uncomfortable. Patients could have ovarian cyst, ascites on the right. That's usually caused by liver failure. That is once you see that again, you will be able to remember it forever, because it's a very particular shiny bulging abdomen basically. So when they have all this fluid in there, that's why if you did do percussion, this is where it would be beneficial, but usually in these patients you don't have to do percussion to know that there's fluid in there, because that's how their abdomens get so swollen. So they could get fluid out of whichever way they're laying dependently, you could find some fluid in there. I would read through this. This is, especially if any of you ever do med-surg, which you will at some point due to your clinicals. Small bowel obstructions or any sort of intestinal obstructions are very painful. These patients are the ones that are going to get an NG tube so that their bowel can rest and hopefully resolve itself. But these are some signs and symptoms. I won't read them off to you. But it's good to know, because this could be one of your patients. These patients either need bowel rest, and hopefully that with that their stomach and intestines can relax and open back up, or they require an NG tube to help with bowel rest, or they require surgery. Okay. So abnormal, hypo, and hyperactive. Sure, if your patients are not feeling well and they haven't eaten, or they've been very sick, like they're probably going to have hyperactive bowel sounds. These are all the organs that can be enlarged. That's an example of an abdominal aortic aneurysm, what it looks like. It should be thin down the center. Different developmental considerations are normal. Infant and children, you can obviously see the umbilical cord a little more prominently because it's healing. Liver takes up more space in the abdomen, and the bladder is a little bit higher. These are pretty standard pregnancy symptoms. I'll let you read through those, but I'm not going to go through each one. You can see it says skin changes on abdomen includes striae, and linea nigra is just that line down the center. Striae is the one on the left, the stretch marks here. Important to know pregnant women with their abdominal swelling, I guess you would say, these patients you wouldn't want to lay flat on their back. If you have someone who's 8 months pregnant, that laying flat on their back is going to compress those major organs that are supplying blood flow to their body. So really making sure you have them on their left side is important for these patients. So aging adult, the big thing with aging adults that I see the most is, constipation is a much bigger issue for them. Things are slowing down a little bit. These patients get bowel obstructions really easy. So if they're starting on a new narcotic or any sort of medication that would cause constipation, I'm very, very, very serious about my patient education on how to prevent constipation here, recommending they start a stool softener or something like that. All right. That's all we got, so I'll see you guys in the lab. Thanks.